Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Welcome to today's episode where we're going to be discussing a new international clinical practice statement that was just published last month in the Cardio-Oncology Journal. This was a collaborative effort between ICOS and the Multinational Association of Supportive Care in Cancer, MASC for short. And this is really a unique contribution to the literature because it was largely produced by and for hematologists and oncologists, where in the past, so much of the literature has been focused on the cardiology community. So we're really pleased to have with us several of the leading contributors to this project. First, I want to welcome back one of our regular contributors, Dr. Susan Dent, medical oncologist at the University of Rochester, immediate past president of ICOS, and the first author on this publication. Welcome, Susan.
Thank you.
It's always great to have you. And I'm also pleased to have with us, representing MASC, Dr. Bogda Kaswara. She was the last author on this publication. She's an internationally recognized clinician researcher with an expertise in cancer survivorship and supportive care. She established one of the first cancer survivorship programs in Australia, and she serves as director of the Australian Research Centre for Cancer Survivorship and is the chair of the ICOS Survivorship Working Group. So welcome, Bogda.
Thank you. Great to be with you today.
And then we also have with us one cardiologist who contributed to this project, Dr. Jose Alvarez Cardona, longtime active member of ICOS, serving now as assistant professor at New York University and Langone Hospital. Welcome, Jose.
Thank you for having me.
It's great to see you again. Let's start at the beginning. Susan, I wonder if you could start by describing for us just how this paper came about. What was the clinical landscape that led to the development of this statement, and what gaps were you seeking to fill?
Sure. Thank you, Stephen, for asking me that question. I think as a cancer provider, along with my colleague Boda, we've witnessed the growth in survivorship. And people are surviving a cancer diagnosis. Those with advanced disease are living longer. But I think increasingly we've recognized that cardiovascular disease is a major competing cause of morbidity and unfortunately mortality in individuals. And that is being recognized amongst healthcare providers. This had led to a number of professional organization statements or guidelines, including the latest, which was published by the European Society of Cardiology in 2022. And prior to that, ESMO, or the European Society of Medical Oncology, published a guideline, as well as the Canadian Cardiovascular Society, ASCO, the American Society of Clinical Oncology, and the ACC, the American College of Cardiology. So you've seen there have been a number of different professional organizations that have published guidelines or statements, but the majority of these have really been focused on cardiologists and how they can care for cancer survivors, with, I think, less emphasis on what should oncology or cancer care providers, how can they contribute to the cardiovascular care of cancer survivors? And so we recognized, in speaking to many of our colleagues in cancer care, that there was a piece missing, that they really wanted what do I need to know and how can I contribute to the cardiovascular care of my cancer patients or cancer survivors. So that really, we felt, was a void. And it really led to us coming together as a group to try and produce a very short, succinct clinical practice statement that really reflected what is the basics, what is the minimum that I need to know to take care of cancer survivors.
That's super helpful context. And you ended up with, I think, 5 major recommendations in the paper. It must have been challenging to narrow that window down to just 5. How did you come up with the recommendations that you ended up with in the paper?
Well, that was challenging. So actually, 2 years ago, this month, we had the ASCO annual meeting in Chicago. And that was when we first decided as MASC and ICOS organizations to form a group of individuals from both organizations, including oncologists mainly, but also some cardiologists, pharmacists, people with expertise in exercise, and so on. And as a group, we met virtually to try and drill this down into what are the 5 main themes that we felt were important in terms of developing a clinical practice statement. And there was a lot of going back and forth and speaking amongst each other virtually. But that's how we really did. We did it as a collaborative, collective process, again, focused on a viewpoint from an oncologist or hematologist and what are the basic things that you really need to know.
That's great. I think that's why this is going to be such a helpful and unique contribution to the field, that focus on oncology. And Bogda, historically, obviously, cardiovascular risk assessment has been viewed as really the primary responsibility of the cardiologists. But why was it important to specifically focus this statement on cancer care providers?
Well, I think that the responsibility for cancer care providers recognizes the fact that it is the cancer care providers that consider patients' needs first before the patient might be referred to a cardiologist. So, at this first point of contact, the recognition of cardiovascular risk factors is necessary to decide of what is the best treatment for cancer. And we already know that risk factors for poor cardiovascular outcomes in the context of cancer relate to 2 factors. One is the toxicity of cancer treatment itself, but the second, and a very important one, is recognition of pre-existing cardiovascular disease or cardiovascular risk factors. We know from quite extensive research that these are the patients who end up having problems later. So at this initial moment of treatment planning, the oncology team needs to decide what is already out there that may put the patient at risk. And is that risk factor sufficiently severe that warrants referral to cardiology early so some preventative measures can be instituted? And what aspects of risk management rest with responsibility of the patient in terms of healthy lifestyle? So in order to decide on a safe treatment, cancer care team needs to consider risk factors and how to manage them before the treatment is given. And the final reason is we know that cancer care providers have an opportunity to provide a very important endorsement of the overall care plan. So the importance of management of preventative medications, blood pressure monitoring, following up with appropriate providers, healthy lifestyle. So if oncologists recognize that and act early, that is a very powerful information and resource that can be deployed literally at the time of planning cancer treatment. So there is an enormous opportunity in oncologists and a broader cancer care team taking on that task.
And then this statement, in addition to addressing, as you just said, that the early assessment risk factors prior to cancer treatment, the recommendations you all came up with follow the cancer journey really from the early risk assessment all the way through to survivorship. Why was it important for y'all to create a framework that followed that entire journey for cancer patients?
The reason is because tasks and responsibilities differ significantly at different phases of cancer journey. There is a assessment and risk stratification in the beginning. There is monitoring for problems during treatment. There is planning for follow-up care and secondary prevention after treatment is completed. And most oncologists have very limited time of contact with patients and a number of priorities to deal with. So what we wanted to do is give them recommendations that are easy, actionable, simple, very easy to follow, not too many things to juggle at any given time. And we also know that's how all of us deal with information. We take information at the time point where it's needed. So a practicing cancer specialist does not need to read the entire document when they're addressing the issues of the patient who might have finished their treatment. They might just read the relevant section, and that will save them time and focus their thinking.
And Susan, Bogda just commented on the importance of that risk assessment before therapy begins. What would you say cancer patients and cancer providers should consider before starting treatment in terms of risk assessment? What are the key factors? And then also, what tools are available to guide those decisions?
Steve, I think this is probably one of the key recommendations in this document is that cardiovascular risk assessment prior to starting cancer therapy. So there are some very simple things that we outlined in the document that you can do. And one, of course, is just identifying cardiovascular risk factors or pre-existing cardiovascular disease. So we know our patients come to our clinic and they may have pre-existing hypertension. It may not be very well controlled, or they may have diabetes that is poorly controlled. And not only that is that important for their long-term health, but it also can have a significant impact on the cancer therapies that we're able to offer individuals. So for instance, if their blood sugars are out of control, we may not be able to offer them some therapies that have the side effect of raising blood sugars. So one simple thing is assess cardiovascular risk factors and pre-existing cardiovascular disease. And if those things are not well controlled, reach out to a healthcare provider in your network that can help you manage those. Perform the relevant cardiac investigations. So if you're going to give an individual a cancer therapy that can affect the heart, in particular the left ventricular ejection fraction, then order an echocardiogram. So I think many oncologists are aware of that particular test, and we do that for anthracycline-based chemotherapy and HER2-targeted therapies. And then, of course, measuring things such as lipids is a good thing for everyone if the primary care provider is not doing it. And a 12-lead ECG, I think we forget about that, but it's quite a simple test and it could tell us a lot about cardiovascular health and to see if there's any pre-existing issues that we aren't aware of, because some people may have had myocardial ischemia or heart attacks and we don't know them. And then finally, the risk assessment tools. And I think there are some out there. One, of course, we mentioned in the document is the HFA ICOS Risk Performa. This was sort of a risk assessment tool published in 2020 and endorsed by the ESC Cardio-Oncology guidelines in 2022. But essentially, it looked at 9 different classes of cancer drugs, including anthracyclines and HER2 target therapies, and came up with a risk score based on not only the cancer therapy that you were going to deliver, but also on pre-existing cardiovascular risk factors, any prior exposure to cancer therapy, and so on. So this may not be the perfect tool, and there are ongoing studies trying to validate this in certain settings, but it really was sort of a cancer-specific tool. And since then, of course, Stephen, there are other tools that are being developed for certain malignancies and certain cancer therapies. So I think if you could do those 3 things, think about cardiovascular risk and cardiovascular disease. If the tool applies in the different classes of cancer drugs, apply that and perform relevant cardiovascular investigations. And for the most part, everything I just mentioned to you is relatively easy, simple, and doesn't require a lot of infrastructure support.
Yeah, I think that's so important to make these things easily actionable. And as you were speaking, I was thinking if there's patients who are listening to this podcast, it's so important, I think, for patients to realize if they're coming in with cardiovascular issues, they need to make that known to their providers. I would think if I came in as an average patient, I would think, well, I'm here for cancer therapy. My cardiovascular health is totally irrelevant to this process, but it's actually quite critical.
Absolutely. I think that's getting away from that sort of silos of medicine and that
Mhm.
disease-centric approach and moving towards a person-centric approach, because anything that we do in oncology or for cancer care is going to affect all of you, not just your cancer.
Yeah, so important. Well, one of the emphases in this article is on prevention related to cardiovascular issues, modifiable risk factors like lifestyle factors and exercise and smoking. Jose, why is prevention such a central theme in this document? And how can we make that realistic for patients who, as we said, are now navigating cancer therapy on top of cardiovascular issues? How can we make that actionable for our patients?
Yeah, so that's an excellent question. The way that I see this and why this is such an important topic, it's because there are so many shared risk factors between cancer and cardiovascular disease. And we know that some of the prevention interventions that we can recommend for patients can also help in terms of the outcome of their cancer treatment and cancer diagnosis. There's growing body of literature suggesting exercise, as exercise is beneficial for your cardiovascular health, but it's also very beneficial for your cancer health and outcomes as well. So, and it's not about let me finish my cancer treatment before I run a marathon. No, it's about starting early from the time of diagnosis, because not only it's going to help you from a cardiovascular standpoint, but it's also going to help you from a emotional standpoint, psychological standpoint. You're going to have a routine. And also, I was going to mention that in terms of prevention, these are patients, and just like you mentioned, patients have other issues when they receive a cancer diagnosis that we need to address. And sometimes it's like Susan was mentioning, controlling their cholesterol better, controlling their sugars better, because those are relatively simple things that we can do, and they can have a tremendous impact in terms of the long-term outcomes from a cancer diagnosis standpoint and cancer treatment standpoint.
Before we started recording, we were all talking about the rapidly changing landscape of cancer therapies, including targeted therapies and immunotherapies. Bogd, I wonder, how can management strategies adapt to some of these newer treatments and their related cardiovascular impacts?
One thing that I would say is that oncologists are actually pretty familiar with the concept of adapting to new therapies and monitoring for new toxicities. That's our core business. The entire success of cancer treatment developed on the back of rapid adaptation of new drugs. And it's important to recognize that toxicities evolve over time. So when the drug is released, you might have a certain profile of toxicity that is recognized in a sort of early phase of drug follow-up. But as the drug is being used for 5, 10, 15 years, it becomes apparent that other toxicity profiles might become more prominent. One example is that when immunotherapies became used, one of the main cardiovascular risk factors that was talked about was myocarditis, because it's rare, it's very unusual, it's very severe. But as oncologists became better at managing myocarditis with very close collaboration with cardiologists, what is now becoming apparent is that it is ischemic heart disease that is also a significant problem, and relatively more common because the background cardiovascular disease is common. So I think that it is, in a way, an expectation of oncologists that they need to monitor for toxicities because they see those toxicities and they need to be alert to it. So being in tune with the cardiovascular needs of patients also allows you to do that. But the other thing that I would want to mention, and that ties in a little bit to what Jose has just said, is those background cardiovascular risk factors that patients might present with at the time of the cancer diagnosis are significant predictors of greater likelihood and greater severity of unusual toxicities that you experience with new therapies. So management of those risk factors is really important. And just to reassure oncologists on this, who are listening to this podcast, who might be panicking that now they have to single-handedly manage hypertension and diabetes and obesity and exercise advice, the key message here is not that you have to do it all within the 15-minute consultation, but you need to recognize and work with the patient that this is an important issue and somebody needs to manage that. For some patients, their GPs might already be managing that very well. For others who have complex problems, referral to a cardio-oncologist or cardiologist would be the most appropriate approach. Some cancer centers have very good relationships with primary care providers on site. There are exercise physiologists, there are physiotherapists. There is a range of potential solutions, but I think the key issue for the cancer care team is asking, is it being covered? Who is covering it? And if it's not covered, how can we get it covered?
And then, Jose, moving on to survivorship post-cancer therapy and even completion of therapies, the statement highlights that risk factors don't just end as soon as cancer therapy ends, but there's need for ongoing care. Why is survivorship care such an important part of this picture?
From a cardiovascular standpoint, survivorship is key. Even those patients who exercise, I emphasize exercise because it's something that everybody has access to some extent, right? But in the case of exercise, even those patients who are exercising during their cancer treatment, they do suffer some degree of physical deconditioning despite, let's say, being an athlete before starting your treatment. So in the survivorship phase, it is important to continue whatever you were doing to prevent any cardiovascular complications during your cancer treatment. It should be modified during that phase of survivorship. And patients, yes, they should continue to exercise, but some of the things that we were targeting during cancer therapy may change. Maybe we become a little bit less aggressive because now they're not exposed to certain therapies that increase X or Y, risk for cardiovascular comorbidity per se. So what I usually tell my patients is that, yes, I know maybe I'm adding you one or two medications, but maybe this is only temporary. This is not going to be permanent. This is so that you can complete your treatment. And then after you complete your therapy, you may not even need all of those medications. We can manage it with diet. We can manage it with exercise. We can manage it, with different interventions.
And as Bogda mentioned, there's such a critical importance to communication and referrals between oncology and cardiology. What about post-cancer therapy? How do we improve communication between, say, primary care, who's following up on these patients, cardiology, oncology? It seems like there could be a communication gap within there with all the different people involved. Do you have thoughts on how to make that communication streamlined?
If you're at a center or a healthcare system that you have access to cardiology or to primary care and they were already involved from the beginning, when the patient finishes their treatment and there's nothing active oncology wise, I know maybe they'll have to see the oncologist once a year or subsequently, let them know, hey, the patient has finished the bulk of their cancer treatment. They're going to be seeing us less frequently. We would like for you to continue managing X, Y, or Z. Similar to when they complete radiotherapy or radiation oncology treatment, that there's a completion of treatment. And at least in my experience, you're aware the patient finished their radiation therapy. So that would be essential. Yes, let your colleagues know, hey, patient is okay, no more cancer treatment. Now we need you to be the captain of their care.
That's great. And this was obviously an international effort. Both of these organizations, MASC and ICOS, have an international focus. So, Susan, I wonder if you just comment on how the recommendations here apply broadly internationally. And then what about situations where they may not have a designated cardio-oncology clinic? Does this still apply to them, or how does this work for global environments that may be quite different?
Yeah, that's a great question, Stephen. In fact, I would say, even in North America, the cardio-oncology clinics or services are mainly in academic centers. And we know a lot of cancer care is delivered in the community setting. And so, looking beyond North America, we also recognize globally that healthcare resources vary tremendously. So, we really want to focus on what are some of the things that can occur in some of those countries where they may not have access to cardio oncologists or cardiologists. And it was really about learning how to match the resources in your country to optimizing the cardiovascular care of that cancer survivor. So we go back to the basics, and we've talked about this a little bit already in this podcast, but risk, assessing cardiovascular risk at baseline. And that is something that can be simply done without a lot of resources. Looking at the cancer therapy options, perhaps there's a treatment that's less cardiotoxic in someone who may be at high risk. And finally, as also discussed earlier, we can look at lifestyle modification. Now, that's not easy for individuals to adopt, but it certainly we can discuss that in some of these countries, looking at diet, exercise, smoking cessation, all of these things which we know can have a significant impact on the long-term cardiovascular health of individuals. So recognizing that not everyone has access to a cardio-oncology service or program, absolutely, this clinical practice statement was written so that these principles could be adopted in low and middle income countries, and I should also say, in community settings that do not have specialized clinics.
That is so important. And it's such at the heart of, I think, both our organizations that we want to provide guidance that is manageable. It's actionable for people in a global setting in all different kinds of environments. So that's, I think, a really important takeaway. Baghdad, Jose, do either of you have highlights that you would say are real takeaways for you from this project and this effort together?
I actually think that I should really highlight the fact that amazing things happen when you bring together an international collaborative. It's not so great on managing meetings across time zones, but it really is a really valuable opportunity to consider diversity of needs that patients have and creating something that is actually adaptable and feasible in variety of settings. And I think that's ultimately benefits patients globally.
Yeah.
Jose, any thoughts?
Yeah, so this is my personal opinion. I really like the term that we use, cardio-oncology, because I feel that the main partners here are the oncologists, and we are here to support them through the patient's cancer journey. It's very reassuring when you can call an oncologist like 5, 10 years after the patient finishes their cancer treatment. And there were a lot of questions about what's going to happen. Are they going to be cured, or what is the outcome? And you can call them, tell them, hey, the heart, it's doing okay. They're exercising, they're doing very well. So my point is that, cardiologists are here to support oncologists. And I really like it when it's called cardio-oncology, not so much oncocardiology, because I feel that oncology is like the cornerstone of this.
I think it's about partnerships. I mean, I think this was an amazing opportunity to come together around the globe to put this document together. But ultimately, and most importantly, it's all about improving patient care. And that patient care, I think, can be improved no matter where you are in the world through partnerships, whether that be through oncology or cardiology, primary care, you know, advanced practice nurses, exercise. There's so many people that is going to look different in different parts of the world, but that's okay. You just need that partnership to come together and look after the whole individual, not just their cancer. We need to look after people.
That's so great. Thank you all for your time, not only your time tonight, but really your time and effort that you put in really for more than a year on this project. And I really think it provides a very practical roadmap for integrating cardiovascular prevention and management in the cancer journey. So, very, very thankful for all of you and all the work you've done. We'll put a link to the statement in the show notes for everybody who will want to read it after listening to this. So, thank you all very much for being with us tonight and for this great effort.
Thank you.
Thank you.
Thank you.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.